I'm going to get you set on the basics of this disease. It'll make it easier for you to understand what the other speakers are talking about. And the metaphor that I've been using for a long, long time is a garden. That's because I'm from rural Minnesota. Your bone marrow functionally is a garden. And under a microscope, you can look at that garden and see that there are three major crops within the garden. I'm changing. Yeah. Three major crops within, still need that, okay, great. Three major crops in the garden. About 20% of the acreage in that bone marrow garden is given over to red blood cell production, the cells that carry oxygen, give you your energy. You don't have enough, then you're called anemic. 60% are infection-fighting white blood cells that protect you against the development of infection. About 10% are given over to the production of blood clotting cells, and there are about 10% that are boutique crops that go by a whole host of different names, but they're not relevant to our discussion. But in every normal bone marrow, 1% of that acreage, 1%, are cells called plasma cells. They're protein-producing cells that help protect your body's immunity. And that protein production of those plasma cells, it's an important concept to understand. You get a flu shot, plasma cells will start making antibody proteins to protect you. You skin your knee when you're 4, you're going to have a plasma cell making antibodies to the exposed contaminants that were developed. So that's normal. And if you look at the bone marrow in those proportions, 60, 20, 10, and plasma cells 1, that's what it is at age 4, 14, 24, 84. Those proportions are very, very tightly controlled. No variation. Unfortunately, sometimes malignancy develops. And the characteristic of malignancy, of course, is uncontrolled growth of cells. And what happens to 6 per 100,000 patients per year in the United States, twice as common in African Americans, is that one of those plasma cells loses those growth regulatory controls. Usually acquired genetic changes occur, and it develops a growth advantage, and it starts growing in the garden, that 1% of the acreage. And it'll grow, and it'll grow, and we say by definition, if the acreage is greater than 10% plasma cells, that's defined as multiple myeloma. Average patient with multiple myeloma at the time of diagnosis, that acreage is about 40% on average at the time it's diagnosed. We can go up to 100%. And the consequences of the development of these weeds in the garden, that's the concept that I want to focus on, are threefold. The first one is as the weeds grow, they start choking off all the normal plants so that they're no longer able to germinate correctly. The first consequence of that is it chokes off the red blood cell plants in that garden, and that consequence is a reduction in production of red cells, a drop in the blood hemoglobin level. You are anemic. So for some patients, 70% at the time of diagnosis, weak, tired, exertional, shortness of breath, can't climb the stairs anymore, and the evaluation to the doctors, I'm anemic. And that can go a whole lot of different ways. So some of you may have had a colonoscopy looking for bleeding or an endoscopy looking for bleeding, but the key here is the anemia. So that's 70%. Number 2 is that these weeds don't just stay in the garden. They actually begin to erode into the casing of the garden. Well, what's the casing of the garden I'm talking about? Well, that's the surrounding bone. You go to the supermarket to get a bone for soup, you know the bone's made out of 2 separate parts. There's a thick outer white shell on the bone, which allows you to actually jump on the bone. You wouldn't break it. And then there's that kind of spongy core that's kind of brown and kind of webby. And that, of course, is the bone marrow. And In a freshly slaughtered animal, it's bright red because it's the same color as blood, because that's where the blood is produced. And what ends up happening as these weeds grow, they'll begin to invade the casing, that cortical bone, and start to dissolve and damage it. And that weakens the bone because, as you know, bone is rock hard, but clusters of myeloma cells actually have the consistency of raw liver. And so you replace bone with raw liver, that bone is weaker. And what will happen is, particularly in bones that are under a lot of weight stress, which is spine and ribs, they're prone to fracture. So that would be another 70% of patients. 70% of patients will develop spontaneous rib fractures and pain when they cough, they sneeze, it hurts, they can't roll. And the other thing is that the vertebrae in your body, and you'll see these pictures from Dr. Hillengoss, are actually little building blocks, one stacked upon another to give you your vertical height. And when they get weakened because the weeds begin to erode into the casing, those bones actually give way. It's like stepping on a Coke can that's empty. You can crush it and it'll shorten up. And of course, when it crushes like that, it's intensely painful. And it's particularly, since it's a bone fracture, it's very specific. You lie still, it doesn't hurt. But if you rotate your spine or you flex your spine, it can be quite excruciating. So those are two of the primary features. The third, I'll get to in a second. How does the doctor diagnose it? How do they even recognize what's going on? How do they come from, my back hurts, and by the way, for some of you, you'll notice as you walk around, those crushed vertebrae end up resulting in height loss. And so people can get this disease and get 2 inches shorter, 4 inches shorter as their spine begins to give way under the erosive effect of those weeds. So how does a doctor actually figure this all out? Well, this business about plasma cells making protein, protective proteins, isn't lost when they become malignant. These cells continue to make the protein. The protein is now an abnormal protein because it's all being derived from one population of malignant weeds. And this protein is detectable in the blood and in the urine. And it's actually not the cause of the problem, but what it is a surrogate marker for what's going on in your garden, in your bone marrow. Typically, the more myeloma you have, the more protein you make. And it's critical for you to know your protein. You need to know your protein. It's a big deal in your monitoring. These proteins are actually antibody proteins or immunoglobulin proteins. They're proteins. And these proteins are made out of 2 components. A light chain, and if you don't know light chain, you're at a major disadvantage. You need to know light chain, and a heavy chain. And your physicians use that as indirect measures of the activity of your disease. And they actually use it to determine the depth of your response, your benefit. Now that's an indirect measure. The only direct measure is the bone marrow. So you can have 2 choices. You can get your protein, your heavy chain and your light chain measured every month, or you can have a bone marrow every month. Show of hands. Because really what we're interested in is how much myeloma is in the bone marrow, but we use the protein measurements as surrogates because the working assumption, since the weeds make the protein, that the protein levels over time are a good reflection of how many weeds there are. So if you're killing the weeds, the protein should be dropping. If the number of weeds are unchanged, the protein should be stable. And if the disease is progressing, then the protein should rise. So it's very typical that every month or whatever your monitoring interval is, you're having a measurement of your light chains. There are 2 types, kappa and lambda. You should know which one you have because that involved light chain is a big deal for your provider in terms of what is the activity of the disease. There's also a heavy chain. There are two types typically, G and A, or IgG and IgA. That commonly will also be measured. And it doesn't matter which you have, you need to know which you've got because it's key to your overall monitoring over time. And there's a third measure that, and they're all good measures, where you have a SPEP, and what your doctor will say, and leave you bewildered, we'll talk about your M spike. And the M spike is just another way of measuring the protein. It's different from the way in which we measure the heavy chain GA or the light chain kappa lambda, but it is a legitimate measure of the activity of the disease. So the protein really isn't the problem. The cancer cells, the weeds are the problem. The protein's a measure of the problem with one exception. In 20% of patients, the protein that's produced gels in the kidney. It's produced in your garden, in your bone marrow, hits your bloodstream, then the blood filters through the kidney, and they're light chains, protein, but then they gel and they damage the kidney. So 20% of patients with multiple myeloma present because their kidneys are damaged. In 3/4 of those, that's completely reversible, but still about 5% of patients, even after effective therapy, have residual kidney damage related to the gelling of the protein. That's the only exception where the protein is the problem. Typically, it's not the problem, it's the marker, it's what we use to determine how you're doing over time, and we use it as a response, and it's relatively simple because a lot of these things go back to the 60s. If the protein went down 25%, we say it's a minor response. 50%, it's a partial response. 90%, a very good partial response. 100%, a complete response. And then there's some nuances in there about what does 100% mean and ways to actually dive deeper to find out how really deep the response is. But you need to know your myeloma protein. When I do my second opinions, I see a lot of engineers. I don't know what it is about Rochester, Minnesota and engineers, but they come and they bring me an Excel spreadsheet that shows a graph of their protein and what treatments they've had a long time, and I love them. Because then the next patient brings me 400 pages of useless material that it's very hard for me to sort through, but when I see those protein numbers over time and what the treatments were, it helps me immensely, and believe me, if it helps me, it's going to end up helping you. So preparing for that opinion, I think, is kind of an important thing. So a little bit about treatment. Treatment, fundamentally, no matter how you spin this, is weed killer. You need to kill the weeds. And there's a lot of different brands of weed killer. You can go from table to table out there and learn about each of the different weed killers available for this disease. And some are pills. And some are shots under the skin. And some are pills you take so you can't sleep and your spouse will kill you because of the mood swings. Some make you lose your hair, some don't. But all of them have the same, whether it's chemotherapy or targeted therapy, these weed killers are designed to selectively destroy the weeds, but try to leave the garden relatively intact. But everybody knows that when you apply weed killer to a garden, the weed killer doesn't just kill the weeds. If you give too much, you will damage the normal garden as well. So there are limits to what you can give. There are caps. Even if it's highly effective, you have to be a little careful because you walk a fine line between weed killing and garden killing. And all I'm saying is what you know intuitively is that chemotherapy doesn't just kill the cancer cells, it hurts normal cells as well. So as you're getting your treatment, your doctor insists that you get a blood count every week so they can look at what's going on with the normal cells to be sure we're not overdoing it and maybe need to cut back on the weed killer. And over the last 20 years, these regimens have evolved from 2 pills to 3 pills to 3 pills with injections for antibodies. That's evolving. I'll be talking about that this afternoon when I talk about targeted therapy. But one thing that's typical in this disease is that, one, those therapies, at least to date, are not expected to be an indefinite cure. And that secondly, even if the agents are working really well, the weed killers, you can't give any dose you want because of damage to the garden. That brings us to the next step. There are circumstances when you can actually forget about the weed killer dose and kind of go crazy. Now, if you take a big dose of weed killer, a big dose, and douse it on the garden, you kill the garden. You'll kill the weeds, but you'll kill the garden. You can't live without a garden. You've got to have a garden. No garden, no red cells, no infection fighting. You can't stop bleeding. So you've absolutely got to maintain the garden. So what has been done now, oh boy, certainly 40 years now, is that what's done is we collect seeds. And these seeds normally aren't in your bloodstream, they're in your bone marrow, but you can give shots of fertilizer that Amgen makes, and that'll make those seeds leave your bone marrow and get out in your bloodstream. And when they're in your bloodstream, they can be collected by a machine that essentially is a sophisticated milk skimmer, basically, and it takes the cream layer off and the milk is now low fat, but it takes the seeds out of the bloodstream. Once those seeds are out of the bloodstream, they're frozen. And once they're frozen, then you can go and give a big dose of weed killer designed to kill the garden. But then you can go to the freezer, take out the seeds, thaw them, replant them, regrow the garden. That's the schematic. The terminology, instead of seeds, they're stem cells. Okay. And instead of replanting, it's transplanting. But basically what we're doing is taking very high dose weed killer designed to really eradicate the garden, but not cause complete elimination of garden growth by having seeds. And sometimes, we'll collect seeds for more than one. We'll collect maybe for 2, or maybe we'll collect for 1, and maybe you have 1 in reserve 10 years down the line, or 15 years down the line if it's needed, because those seeds can be frozen indefinitely. And so the concept of stem cell transplant is really designed to work in conjunction with the standard weed killers because it works in a completely different mechanism. Now, those of you who've been through this know that it's not fun to have your garden killed because there's about a 2-week period, 10-day period between when the garden dies off and the replanted seeds germinate and grow. And during that time, it's blood transfusions and platelet transfusions and mouth sores and fevers and antibiotics and I can't eat and I can't swallow. Not a fun 2 weeks. But at the end of it, it's been demonstrated that using that type of treatment increases your time without myeloma and has consistently been shown to deepen the response, meaning the protein goes even lower, it goes from 70 to 90 or 50 to 80 or whatever, or 90 to 100, effective. And then in almost all instances, after recovery, after about 2 to 3 months, a maintenance treatment, low-dose treatment, which I'll talk about because it depends on actually your prognosis and your genetics, designed to sustain the gains that you've achieved. So that once you've killed the weeds, to keep them killed, and that's the third phase, which would be maintenance treatment. I think I've been talking for 20 minutes already. Can I just be sure, in case I don't want to miss anything, can I take 1 or 2 questions? Because I'm running a little ahead? Or you want to save it for the panel?
I'll take 1 burning question.
Yeah. And so there are a couple issues that are going on here. Obviously, since the disease recurs, two things come to mind. Well, maybe you didn't actually kill all the weeds you thought you were killing, or B, maybe there were weeds contaminating the seed collection and we put those back in. So, these types of marking studies have been done in leukemia transplantation, where you actually can mark the cells and so they can be detected. And in leukemia, what's been demonstrated is that when the disease comes back, it doesn't come back from the reinfusion of stem cells. It comes back from cells that were resident in the marrow space that somehow escaped. So then the second question is, well, we can't see any myeloma cells and the proteins are all gone. So where exactly are the plasma cells? And that raises questions about, well, maybe there is a seed parent, if you will, to the myeloma cell that we don't really well recognize, or may be resistant to chemotherapy, or is hidden somewhere in the body and can't tangibly be destroyed by the chemotherapy that leads to the cure. And finally, Dr. Keith Stewart, a Canadian colleague of Dr. Rees, about 10 years ago, did a trial where he took the seed product and put it through a column in an attempt to purify the seeds. Purify them so that only seeds were retained and everything else would wash through. And that was a trial where half the patients got the purified and half the patients didn't get the purified. And what turned out was that the time without myeloma was no different between the two groups. But the group that had the purified seeds had many more infections, probably because immune cells were being also not being reinfused. That reduced patients' kind of immune system against viruses and that sort of thing. And so it's not a panacea. Transplant isn't magic, but the preponderance of the data says it is beneficial in conjunction with all of the other new treatments that I'll be talking about this afternoon. And you're going to hear from Dr. McCarthy more about this business about high-dose weed killer, and he's also going to talk about, well, what if you don't use your own seeds? What if you use your brother's seeds or your sister's seeds or banked seeds from someone who's a tissue match? Because those certainly won't be contaminated with cells of myeloma if you took someone else's seeds, and he's going to be talking about that as well. So I'll see you this afternoon. Thank you.